You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is February 25th, 2011, and I'm your host, Dr. Jay Portnoy. Our topic today, bronchial thermoplasty. Our presenter is Dr. Gary Salzman. He's a professor of medicine and chief pulmonary and critical care medicine at the University of Missouri, Kansas City School of Medicine in Kansas City, Missouri. All right, well, welcome back to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. We're joined today by Dr. Gary Salzman and by Rita Mangold. Dr. Salzman is a professor in the Department of Pulmonary and Critical Care Medicine at the University of Missouri, Kansas City School of Medicine. He's also on staff at Truman Medical Center, and he's the chief of the Division of Pulmonary and Critical Care, right?
Right, that's right.
Here you go. And he's agreed to speak with us today about a topic that gives me heartburn just to think about. It's bronchial thermoplasty, but we've certainly heard a lot about this, and it raises a lot of questions, and I'm sure that we're all very interested to find out what you have to say. So without any further ado, I'll go ahead and turn the podium over to you. You've got the mouse and the keyboard, so
all right.
Away, and welcome to Conferences Online Allergy, Dr. Salzman.
Okay, thanks, Jay. So today we're going to talk about bronchial thermoplasty, and I want to do a disclaimer. I don't have any financial interest in the company that makes it. I'm in no way trying to persuade you to refer patients for this or to in any way endorse this company. Some of the slides came from the company that makes the Alair system, which delivers this treatment. But there are some studies that have looked at this, and so I think we should go through some of the facts about it. So we're going to talk about target patient population, the rationale, the Alair system, the actual procedure, the clinical studies, which I think is really important, and looking at those type of studies, post-FDA approval, and then we'll open it up to discussion. I actually have a video that if we can get online that we should be able to watch the procedure. So, okay, so what is it, first of all? And so it's a means to deliver thermal energy to the airways via bronchoscope to reduce airway smooth muscle. That thermal energy transfers into heat. The temperature is 149 degrees Fahrenheit, so it would be similar to a hot cup of coffee. And it's an outpatient procedure. There's actually 3 bronchoscopy procedures that patients would have to do for this procedure. And so that's basically what it is. You guys are all familiar with the numbers here in terms of, a lot of people diagnosed with asthma, a lot of unscheduled office visits, a lot of ER visits, hospitalizations, and deaths. Although actually deaths from asthma are down to about 4,000 a year. They peaked out around 5,500 or 6,000 deaths a year. So we are making some progress. But there certainly are a group of asthmatics that are more severe. And you guys are all familiar with...
Is that right? 11 people die every day from asthma?
Yeah, that's right.
Oh my God, I didn't know that.
In the whole United States.
In the whole United States? Still, it's a lot of asthma.
And it's probably, those deaths are probably preventable.
I have no doubt.
Yeah, but these are preventable deaths, right? So this isn't something that would be unpreventable. These are preventable deaths.
Wow.
You guys are familiar with the stepwise treatment of asthma and talking about the different treatments. And of course, what I'm dealing with a lot in my practice is patients that would need some of these higher dose inhaled steroids, omalizumab. These type of patients are the patients that are frequently referred to me. As you guys have experienced in our asthma clinic, we get referred patients who have not responded to other therapies and have been more refractory to asthma. And so this is the area and the patients that are on these type of therapies on high-dose inhaled steroids, LABAs, oral corticosteroids, and omalizumab that are still having problems. This would be the group that we are talking about may need alternative therapies that aren't available. And that's really why bronchial thermoplasty was kind of devised for these subgroup of patients that were having more disease and were requiring fairly intensive therapy and still not even responding to that. So this is the group we're looking at. So we basically have an unmet need in severe asthma. There are certainly, and you guys have seen them in my clinic, patients who, despite all treatments, still have uncontrolled disease, are still coming to the ER, are still being hospitalized despite maximum therapy, including omalizumab. Many of them are still having problems. And those are the kind of patients that are seen in referral centers, tertiary care centers, where people are referred for refractory asthma. So that's why this was developed. So you all know your anatomy here, the normal airway, and we have a smooth muscle around the airway, and then an asthmatic airway here, which has a more thickened smooth muscle. And certainly in an asthma attack, we know that this airway is going to constrict, and you're going to have bronchoconstriction. Now, obviously, one important thing is missing from the slide, and that's what? Do you guys know what's missing from the slides they're not talking about? That you think is what? Mucus and edema, right? So there's nowhere in the slide that talks about inflammation, edema, or mucus. So this is only really a part of the story, is the smooth muscle constriction and bronchospasm. It's certainly an important part, but it's only part of the problem. So certainly you're also going to have quite a bit of airway inflammation. You're going to have mucus production. You're going to have hypertrophy of mucus gland, thickening of the basement membrane. So there's a lot of other pathology involved. But one of the pathology is airway smooth muscle, and it appears to be thickened in asthmatics. And then when it constricts, you have severe bronchospasm, and that's when people have an asthma attack. But as you know, you're also going to have huge amount of airway inflammation, which is not shown on this slide. And that oftentimes is one of the causes of exacerbations, is the airway inflammation, edema, and mucus production. So this is part of the story, but not the whole story. So what does bronchial thermoplasty do? So it reduces airway smooth muscle, reduces bronchoconstriction, reduces exacerbation, and improves quality of life. So those are some of the things that it does. But again, it's only really addressing the smooth muscle bronchoconstriction. It's really not addressing airway inflammation or mucus. That's an important point. So this is the system. This is the catheter that's used. Basically, it's attached to this radio frequency controller, the Alair system, and it delivers energy. And basically, as I said, we generate about 149 degrees Fahrenheit. That's generated for 10 seconds at various parts of the airway. There's no visible airway burn that you can see, but there is damage to the smooth muscle, and the goal would be to decrease the amount and thickness of the airway smooth muscle by this radio frequency application in the airway.
Does it use the same principle as like a microwave oven? Is it microwave?
It's radio frequency.
It's radio. It's higher frequency than microwave.
Yeah, so it's radio frequency.
Waves.
Yeah, so it's radio waves, right. So
what size airways are we talking about?
3 to 10 millimeters airways. So we're talking about 3 to 10 millimeters of airways is what we're going to treat with this catheter. That's the size. So this is a picture, a bronchoscopic local methacholine challenge. And in a local methacholine challenge, what you do is you have the airway, and you actually inject methacholine, and you see bronchoconstriction. And so what they're trying to show on this slide, and there was a video, but I couldn't get it to reproduce on this, but this is an untreated airway, and with methacholine, it constricted. This is a treated airway. And you can see with the methacholine, that this airway is maintained its size. So this is untreated, so this is some bronchoconstriction, and this is treated. It was previously treated with thermoplasty, and so this airway is obviously much larger, and it did not constrict with methacholine. So this is kind of the mechanism of action of how it works. But you can see this is smaller than this. And they both should constrict with the same amount with methacholine, but this one was treated.
Can you tell by looking at it that it was treated? You don't see like any scarring or
No, there really isn't any visible, even at the time of the procedure, you're not going to be able to see any scarring.
You just have to remember that that's the one you treated.
Right.
And it looks like it's a pretty local effect.
Yeah,
it's not,
local.
It doesn't treat like a large number of them,
Right.
so you're having to treat each little hunk.
I got a little map I'll show you here in a second. So in pathology, this is the airway smooth muscle here, pre-treatment. This is in a dog. And you can see all the muscle here that's surrounding the airway. after treatment, airway smooth muscle is markedly reduced. Now, what is this blue stuff is collagen. So you are going to have some collagen formation here. This is lung parenchyma here, and this is the airway, the ciliated epithelium. So the epithelial layer, really is not damaged at all, but you reduce the amount of airway smooth muscle significantly in these biopsies from dogs.
Is that beneficial to have the collagen remodeling kind of thing?
Well, I mean, and I'll talk about that. They do have some studies out to 5 years. One of the concerns is, are you going to get fibrosis, and are you going to get scarring, and is that going to cause worse problems? We do have data that's 5 years out that shows that there's no fibrosis, or there's no late effects, because I think that was one of the people were worried about. Are you going to have? But I think when you eliminate the muscle, you're going to have something that replaces it. But it is collagen. But the airways don't appear to be fibrotic or constricted, because of fibrosis. But that would be a concern.
I'm intrigued by the fact that the muscles are more sensitive to heat than other things.
Yeah.
What makes them so heat sensitive?
I don't know. That's a good question. I don't know whether it's their vascular supply. They're very vascular. They have a lot of vascular supply. And whether you cut off the vascular supply to them, or whether you get some coagulation necrosis of the muscle. But yeah, the cilia, looks, it's all intact. But the muscle basically is gone.
You think that the cilia and the epithelium will be more fragile and be more likely to be damaged?
Right. You would think so. Right. But it appears to have more effect on the muscle. So this is basically the map of what's done. And so it's 3 procedures. Procedure 1 is the right lower lobe. And basically you start distal, and then you go proximal, and then you go at each of these sites. So procedure 1 is right lower lobe. Procedure 2 is left lower lobe. And then the third procedure is the both upper lobes. Now we don't do the right middle lobe. And the reason we don't do the right middle lobe, well, why would you think that we would not do the right middle lobe? Anybody know what Lady Windermere syndrome is? Ever heard of Lady Windermere syndrome? Lady Windermere syndrome is from the Oscar Wilde play entitled Lady Windermere's Fan. And Lady Windermere was a very prim and proper woman back in the Victorian age. And what Lady Windermere syndrome is basically recurrent infections in the right middle lobe, namely Mycobacterium avium complex, MAC. And what is purported is that prim and proper ladies don't like to spit, and they won't cough. And so mucus builds up. And in terms of anatomy, the right middle lobe, the way it comes off and the lack of cartilaginous support, is this is really prone to having atelectasis and retention of secretions. And so the right middle lobe is an area where you can get recurrent pneumonias, recurrent infections. And the classical Lady Windermere syndrome is basically atypical mycobacterium infecting the right middle lobe. And one of the theories is it's in someone that has cough or mucus production, but that refuses to cough or refuses to produce sputum because that would not be socially acceptable. So that's the Lady Windermere syndrome.
So why wouldn't you want to treat it with the thermoplasty?
Well, because then if we damage this right middle lobe, and if the muscles keeping this open, if this collapses, then they would get atelectasis and then in fact recurrent infection in the middle lobe.
But isn't the idea to get rid of the muscle so it doesn't collapse, so it's more open, and maybe you wouldn't get as many infections?
That would be the thing, but it was thought that because of the right middle lobe syndrome and the angle the right middle lobe comes off, it's very prone to atelectasis, and so there was kind of a fear of not treating the right middle lobe because that you could create this right middle lobe syndrome, and so it was decided that the right middle lobe would be spared and it wouldn't be treated. But you're right, if you have more bronchodilation, then maybe you would have less atelectasis. And in fact, right middle lobe syndrome in children is seen, and that is mainly from bronchospasm. That's mainly in asthma. So that's more.
My guess is that the company probably didn't want to study doing that lobe because so many people get pneumonia in it, it would be blamed on the thermoplasty.
Right.
So this way they can't be blamed for it. It
Right.
can be an adverse event.
That's true. That's true. So the right middle lobe is X'd out, and now you guys know about Lady Windermere syndrome.
Yeah, thank you.
You could read the Oscar. You could read the
Let's go read it.
That's right. So each procedure will take between 30 and 60 minutes, and basically you're going to start as distal as you can and then just keep coming proximal in each of these areas. and delivering 10-second burst of 149 degrees Fahrenheit temperature. But yeah, they undergo 3 separate bronchoscopies at about a week apart. So you do one procedure, you wait a week, then you do another procedure, and then you do the third procedure.
So how many burns per procedure?
What's that?
How many burns per procedure
It's not.
approximately?
It's just based on what you see endoscopically. So you go as far as you can go, and then then you retract it, and you come back every 10 millimeters or so, and then you keep coming back until you get to a larger airway. So it's depending on the patient's anatomy. There's not a specific number of treatments. But these are, you go to all of these sites except for the middle lobe, which you spare. Now, as you would think, that short term you're going to have an increase in asthma symptoms. This has not only the potential, but it does short term make asthma worse. And so what happens is patients do get prednisone. So they'll get 50 milligrams of prednisone 3 days prior to the procedure. They get a dose the day of the procedure, and then they get another dose the day after the procedure. So they will get 5 days of prednisone surrounding each of the bronchoscopy procedures. And we can talk about some of the complications. So this started, the first feasibility study was done by Cox up in Canada. I think he's at McMaster's. Started at around 2002. They did 16 patients. This was mainly just a feasibility study. Could we do this? Does it cause any bad complications? And in fact, they do have, as you can see, they have 5-year data from these patients. And these patients did have some improvement, and it has maintained over 5 years, and they haven't noticed any fibrosis or any, at least, adverse events in the airways. They've had repeat bronchoscopies, and there isn't any airway scarring or damage. So feasibility study was 16 patients. The next study, again, was done by Cox Group, and this was called the Asthma Intervention Research Study, AIR. And this was an interesting study, and the design of this study I just think is just fascinating. The design of the study is more fascinating than actually the study, because they wanted to have a group of patients that were currently controlled, but then they would make them uncontrolled. They could do bronchial thermoplasty. But if for some reason it didn't work, that they would have an escape valve that they could make them controlled again. So they wanted to have patients that they could kind of, work with their control. So what they did is they took patients that were stable on a LABA and an inhaled corticosteroid. They stopped their LABA, and the vast majority of them became uncontrolled. And then they were able to do the bronchial thermoplasty, and they were able to see some improvement. But they always had that option that they could start the LABA back to get the patient back under control. So I think the design of the study is really fascinating, particularly with the recommendation from the FDA is that once a patient is stable on an inhaled steroid and LABA, you're supposed to take them off the LABA and step-down therapy. And here in this study, they're getting the patients into the study. That's how they got their uncontrolled patients, is stopping their LABA. I thought that was a fascinating way to create patients with uncontrolled asthma, and then also having an escape valve that you could go ahead and control the patients by starting them back on their LABA. This study was really interesting because they looked at a lot of pulmonary functions findings, FEV1 and lung function. There was really no difference in FEV1, resistance, conductance. Their only difference in lung function was peak flow. There was some improvement in peak flow. And then there was some improvement in some of the, like the asthma quality of life survey and some other, and there was a decrease in exacerbations. But there wasn't any improvement in FEV1 here. There's another smaller study they did. And then Mario Castro, who's at Washington University, he's actually a UMKC grad. He was involved in the asthma intervention research study too. And this was a larger study, and this was 190 patients. And I remember when they were talking about this study was not blinded. Obviously, it would be difficult to blind a patient whether he had bronchoscopy or not. And this study was criticized because the main criticism was, well, once you have a patient that undergoes 3 bronchoscopies, they're gonna think they got better, whether they're better or not. I mean, they're gonna think if they had to go through this 3 times, they're going to feel like they got better. And so they really thought that we really needed to do a sham trial with sham bronchoscopy versus real bronchoscopy to see if these results are real. Because, yeah, people go through it. So this study is actually a sham controlled study. So all the patients got 3 bronchoscopies. And it was a 2-to-1 randomization. So twice as many patients actually got thermoplasty, but the randomized that got placebo got the bronchoscopy, actually got the catheter inserted, but no radiofrequency waves. The patient did not know that, whether they got, and the asthma treater did not know. There was an interventional bronchoscopist who was not involved in taking care of the patient, who did the procedure. And so the bronchoscopist was the only one that knew whether they got thermoplasty or not. The treating physician and the patient did not know. They obviously all knew they got bronchoscopy because they went through the procedure. But I think that this, that was really an important part of it, because you're going to have a tremendous placebo effect with these patients if you can put them through that procedure.
Is there any change? You mentioned there's no change in FEV1 or other lung function parameters. What does it do to the bronchodilator effect pre and post?
In fact, methacholine, they did methacholine challenges on them. There wasn't any change in their methacholine challenge, because you would expect, you'd say, okay, well, once you do bronchotherapy, it's going to take you more methacholine, a higher dose of methacholine. But it did. Methacholine, PC20s were the same. FEV1 was the same. You would expect, there would be some differences. Peak flow was a little different, but, it was 40 liters per minute difference, which is really not very much. That was the difference.
It makes sense to me, because when you show the picture when they injected the methacholine, it was clearly a difference.
Yeah.
You can't measure it by any objective way to see that same difference.
Yeah, apparently not, because when you do the pulmonary functions, they're pretty much no significant difference in the treated versus the untreated. So it was, and I remember when this was being reported, and they were saying all these subjective things were better, and I was very skeptical, thinking, okay, well, if they're all subjective, there's no objective measures that are different. They're only the subjective measures. So this has got to be all placebo effect.
What about hospitalization?
What?
What about hospitalization?
That has been improved, and I'll show you some of that. So 5-year follow-up from the original one. Stable PFTs, no clinical complications on adverse event reporting. Annual CTs for 5 years. All the patients were doing well. And so for 5 years, and that was one of the big questions, what does this do to people long-term? Does this make them worse off? Does this cause some kind of fibrosis? So there was pretty good long-term data, 5 years. The AR2 trial, this is the sham placebo trial. So this was a severe persistent asthma, symptomatic despite high-dose ICS and LABA. So these patients actually were uncontrolled despite ICS and LABA. So they didn't drop off the LABA here. They kept it on. And these patients were uncontrolled even at that degree. So this would be this is the type of patient you're actually going to treat. Where the first study is you're not going to treat a patient who's not on a LABA. And then they used the Asthma Quality of Life Questionnaire. Why did they use that as a primary endpoint? Because that's the one that showed the biggest difference in the prior studies. That's how they choose their primary endpoint. You would think it would be FEV1, but all the prior studies showed no change in FEV1, so they didn't pick FEV1. They picked AQ, LQ. Also, there was no difference in the asthma control, the Juniper test, because you remember FEV1 is part of that. So there wasn't any change. So 2-to-1 randomization, thermoplasty, sham, and then all of them were on ICS and LABA, and 2/3 of them got thermoplasty and 1/3 of them got sham. They did about 300 patients in 30 centers, follow-up for 1 year during the study, but then planned 5-year safety follow-up for all the patients. The AQ, LQ, more than 80% about 79% of the patients had a more 0.5 increase. Interestingly, if you read the article, the sham group improved their score by 1.16. This is the patients that got sham treatment. And then the other patients that actually got thermoplasty increased by about 1.4. So there wasn't a lot of absolute difference in terms of asthma quality of life, and there was a tremendous improvement in even in the sham placebo group. So that was very interesting.
But what you're showing here is the frequency of response.
Correct.
And was that different?
Yeah, that was different.
So
Yeah.
the frequency of people who got better was better in the active group.
Right. But the absolute difference wasn't that, and all of the patients had improvement. But this is stuff you're asking about, in terms of clinical tips. So about a 30% reduction in severe exacerbations, 66% reduction at days lost from schoolwork, 84% reduction in ER visits, 73% reduction in hospitalizations, and these were all statistically significant. So these are obviously more of the real-world kind of outcomes that we're really looking at, and there was an improvement. And again, this is a good design because you've got a good placebo-controlled group, where it's a sham group where everybody thought that they got the procedure. With all, they did 850 total bronchs on these 300 patients. No, really bad complications, and these are really unusual anyway for bronchoscopy. And these would just be the complications of bronch. There was no airway stenosis or focal narrowing. That people worried about that. Were you going to scar the airways? Nobody died, thank God. This is kind of interesting, though. It was not without complications. So about 3% of the patients had an event related to the bronchoscopy. And as you can see, most of these were on the day of the procedure. And overall, about 10% of the patients in 3 bronchs had an adverse event that required hospitalization. So you're talking about, overall, about 10% of the patients needing to be hospitalized after their bronch. And for each bronch, it's about a 3.5% chance of having to be hospitalized for the bronchoscopy. So, I mean, it's not a benign procedure, and this is certainly concerning in terms of risk. What's that?
What kind of event?
Wheezing, bronchospasm. Okay. So basically, after the procedure, they start wheezing, and they don't stop, and you have to put them in the hospital and get steroids and frequent. So that was basically the most common.
They probably would have had a lower threshold.
Oh yeah, right.
It's like here's something good. I don't want anything bad to happen.
Yeah. Right. But still, that's pretty significant. I mean, if you think about after 3 procedures, 1 in 10 patients needed to be hospitalized. So that's significant. So despite a transient worsening of the asthma, usually within 1 day, it usually resolved within a week. But then after that, they had improved quality of life and decreased exacerbations, ER visits, decreased in days lost from work. So, those things, all got better. So these are some of the studies and looking at the difference. There was no difference in oral steroids in the first initial study, and you notice that they didn't use that as an outcome in any of the other studies. But the asthma quality of life questionnaire, was a primary outcome here. There was a difference. Exacerbations, ER visits, days missed from work. These were all significant except the oral steroids, and the initial group was not significant. So FDA status, it is approved by the FDA for treatment of patients 18 and older that are not well controlled on inhaled steroids, long-acting beta agonist. The problem with the procedure, and this is why it's not being done very much, is that there is no diagnostic, there's no treatment code for this. In other words, there's no billing code for this. No one has agreed to pay for this. It's obviously somebody. Belinda asked me how expensive it was. So each of those catheters are $2,500 a piece, and they're single use for 1 patient, 1 procedure. So a patient has 3 procedures, then that's $7,500 just for the disposable catheter. And then the radiofrequency generator costs $50,000. So right now, there is no reimbursement for it. Medicare doesn't pay for it, Medicare doesn't pay for it, no private insurance will pay for it, even though it is FDA approved. So I talked to the people at WashU. They have obviously the equipment because they were involved in the study. They have a few people who have come and paid out of pocket for it, just because that they, felt like this was going to be something that would help it. But right now, there's really no reimbursement for it. So that's, that's probably one of the big issues in terms of if nobody's going to pay for it, then obviously it's not going to be very popular. And I still think that there's some unanswered questions in terms of really what is the mechanism. I'm suspecting that this isn't all just direct effect on the smooth muscle. There may be some transmitters and some cytokines and other things that are affected by this heat, and that probably there is some neuromediators that are involved in this that we are not aware of yet. Because it's hard for me to believe that you're going to be able to destroy that much smooth muscle in the lung to have that much significant effect. on their airways. And if you did, then why wouldn't you see improvement in FEV1 and other things? So people are postulating there may be some mediators that are affected by this that actually play a role in inflammation too, that may attenuate some degree of inflammation too. So it may not just be on the bronchoconstriction side, but it may have some mediators. And then the 10% hospitalization rate, I think is significant. Something that you really need to be concerned about. The selection group for these patients is really tricky because you can have somebody that has really bad lung function. They have to have FEV1 greater than 60% of predicted. So this is a patients who have frequent exacerbations and have uncontrolled asthma, but have maintained, reasonably, obviously not normal, but reasonable pulmonary functions. They're not these people with FEV1s that are 40 and 30% predicted. Those patients would not be candidates because obviously if you worsen their lung function transiently, we could kill them before they would have a chance to get better. So they have to have FEV1s greater than 60% predicted. They have to be stable for a month. They can't have any viral infections or any recent exacerbations. So they have to be relatively stable before. And then if you're taking these people, you're going to be hard to find people that have been stable for a month who you're doing it because of unstable asthma. Because somebody that's having frequent exacerbations, it's got to be stable for a month before you can do the procedure. So
maybe in July.
Right. That's right. When the allergens are not out there, right?
See, Brock has a question.
Yeah, sure.
Go ahead, Brock.
Oh yeah, interesting procedure. I was kind of wondering if any of those data were stratified by age.
They were not. They were all they're all over 18. And I think that, most of the people in the study were basically young adults. They were all, pretty much between about 18 and 45. But they did not stratify them per age, no.
Has anyone done lavage studies after following the procedure?
No one has done that, and I don't know if they've done any looking at any mediators, too. But you'd really be interested to know if this somehow affects some type of cytokines or mediators in the lung. And I think that really needs to be looked at.
I'd want to know about like E&O. And
right.
They didn't even do E&O.
Yep.
That'd be easy.
That's right. Yeah. Right. Right.
And I guess the only other one, I had it on my mind. A COPD. Is there any effect on that, or is that the degree of COPD make up the difference, or?
It's never been looked at in COPD.
Of course, people at that age with asthma would probably have a combination. So, the people who have more or less COPD and asthma, the ratio have a different ratio response.
Yeah, I don't know. It's never been looked at in COPD. And COPD is classically thought about as fixed airway obstruction,
right?
Where asthma is more reactive airways disease. And so the thought is that this is more in reactive airways disease where you have more vigorous bronchoconstriction to try to attenuate those. Where COPD, a lot of COPD is with emphysema, you lose supporting structures, and so your airways collapse because they don't have supporting structure. It's not just because of smooth muscle constriction. It's lack of supporting structure in the lung with emphysema. So
maybe
it's probably
if they give them all that collagen, maybe that'll give them support. Maybe it'll help.
That's right. Maybe so. So 18 and over, inadequate control despite combination ICS and LABA, able to undergo bronchoscopy. Let's see.
Got to select the window. Go ahead.
We've been asked to do this, and I've talked about it, but obviously there's no way that I'm going to do this if we can't get the hospital paid for it. It's really not a difficult procedure to do. It's really a pretty standard bronchoscopy procedure, but the main issue is whether there's going to be any reimbursement. And I think the group of patients that this would be indicated would be very, very small. It would be a very small group of select patients that you would do this in. But apparently there have been some patients in St. Louis that have had miraculous type of improvements. And Mario Castro has a couple patients who flew there from other places just to St. Louis, paid cash to have this done, and they had these tremendous results. So let's see, can I somehow do that?
Let me try. Can I have the keyboard? Do we want to do a video or we want it to play? Is that right?
Yeah. Look at that link.
Can I ask a question?
Yeah, sure.
For those patients that have the procedure, even though their exacerbations are supposedly less frequent, when they do have an exacerbation, it'd be harder to treat.
I don't know. They appear to be treated, in this study, most of them only had hospitalizations after 1 day. So, they were in the hospital.
You think, well, if you get rid of the smooth muscle, then the effect of beta agonist or LABA would be less.
Right.
When you're trying to treat an acute exacerbation.
That's true. I didn't see anything in there that they were harder to treat or had
needed more steroids or something rather than.
If you click on the picture, it should play the video.
Just have to reconcile. There's no objective improvement at all. You know what I mean?
Peak flow. That would be the only
The
thing.
peak flow, yeah. Okay.
Do you have video? Do you have audio?
Yeah.
Bronchial thermoplasty is performed with the use of the Alair catheter. The catheter is extended as far as possible under direct vision.
You can make it full screen.
At its distal end,
Good. All right. I shouldn't make it full screen. No. Let's try that one again. Where did it go?
I wonder, yeah.
There it is. Disappeared. I don't think.
I'll just do it in the box. That's fine.
We'll do it in the box. Try that one again.
bronchial thermoplasty is performed with the use of the Alair catheter. The catheter is extended as far as possible under direct vision. At its distal end, there are 4 wire electrodes, which are expanded by means of an external handpiece attached to the proximal end of the catheter. A green wire that runs down the center of the catheter connects the handpiece to the electrodes. When the wire electrodes are expanded, they are brought into contact with and fit snugly against the airway wall. The 4 wires are covered with white insulation proximal and distal to the active regions of the electrodes, which can be seen as 5 millimeter sections of uninsulated wire on each leg of the catheter. It is important to move the expanded catheter with the patient's respiration in order to maintain contact at the treatment site. Airways adjacent to the heart move with each heartbeat, as seen to the left of the catheter, since the treatment is being delivered to the right lower lobe. After a site has been treated, the catheter is partially collapsed to allow repositioning. It is withdrawn approximately 5 millimeters and then expanded again to treat an adjacent site. This process is repeated, moving in a distal to proximal fashion to treat airways 3 to 10 millimeters in diameter beyond the main bronchi in a contiguous fashion. The expanded electrodes deliver controlled radiofrequency energy for a period of 10 seconds. In the airway wall, this radiofrequency energy is converted to heat. There is little, if any, direct visual evidence of heat effect on a treated airway wall.
So it's interesting. It'll be interesting to see if insurance companies are going to pay for this. It's not an inexpensive procedure. And if 10% of the patients need to be admitted, that increases the cost too.
Those people that have data in 5 years, or even the ones that they have data for a year, or don't have data for a year, if they looked at hospitalization rates and ER visits and the cost of all that, I would think that if it's 75% reduction or whatever it was, like in ER visits or exacerbations, there's a cost associated with that.
Right. That's true.
Mm-hmm.
So what do you think, Jay? You think they're going to get reimbursement for this?
Eventually. Not right away, but nothing new gets reimbursed right away. It always takes a long time before health plans agree to pay for things. I mean, we're just now starting to get E&O covered, and we've been doing that for how long?
Right. I'm surprised the FDA approved this without FEV1 data, because the FDA is really all about objective measurements about FEV1. So I was really surprised that they approved this without objective measurements of lung function improving.
But wouldn't this go through a different group of FDA than drugs? This would be more like devices.
Right, devices, yeah.
So their standards might be different.
Right. Yeah, because this is a device, right.
All right.
Any other questions? Where did they first get the idea? Like, I
What is
assume that Allaire probably, they needed studies on like mice or dogs or something.
I mean, they started with dogs.
And just said, we'll decide to use this frequency and make this.
Well, I think it was trial and error. I mean, they probably used higher and lower.
Okay. Yeah.
Turned up some
dogs really did get heartburn.
Okay. They just said, see if we can burn the muscle away and see if that helps.
Right, but I think it's got to be more than the muscle. I think there's got to be some, inflammatory mediators that are involved in this too, or neuromediators. I don't think it's all just a physical muscle thing.
It would have been really nice if they did ENO.
Right. To see whether there's a difference in.
Yeah, if they had a clear drop for ENO after the procedure.
Right.
Theoretically, it would be necessary.
Proposal for a study.
Yeah, right. I'm sure there's going to be more studies going on down the line looking at this. But it is, there's a UMKC connection here. Mario Castro is the PI for this study. He's the UMKC grad. The guy, Alex Chen, is the interventional bronchoscopist that did most of these procedures. He's a UMKC grad, too. So
wow. Did you train him?
Medical school I taught them, but not they both did the fellowship at WashU.
Oh.
They did the fellowship at WashU and residency at WashU, but they did medical school here. So,
Very good.
Kind of a nice connection. So, all right.
All right. Thank you so much. Are there any other questions before we close this session of online conferences on online allergy?
This has been an ACAAI production. To learn more about Conferences on Lyme Allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.